Bismillahirrahmanirrahim. These two topics, pre-eclampsia and eclampsia, they come under the heading of obstetrical emergencies, and these are the complications of gestational hypertension. When a pregnant woman is experiencing hypertension after 20th weeks of the gestation, and she is going to have end organ damage, proteinuria along with them, or any seizures they tend on to develop along with hypertension, then it is known as eclampsia. So these are the complications of gestational hypertension. These are the types of obstetrical emergencies. In case of pre-eclampsia, there is a new onset hypertension after 20th week of gestation. If a pregnant woman is experiencing gestational hypertension before 20 weeks of gestation, it is known as chronic hypertension. But if there is new onset hypertension after 20th week of the gestation along with the proteinuria or end organ dysfunction, it is known as pre-eclampsia. And these definitions are particularly important when we are diagnosing these conditions. A scenario can be given that is a 28-year woman. She is having new onset hypertension at 32 weeks of the gestation along with the edema or frothy urine. Frothy urine means that there would be protein in the urine along with the visual changes or headache that are the indications of end organ dysfunction. So this scenario would be characteristically of the pre-eclampsia. And one of the most important scenario that would be going to asked in this scenario would be that what is the best step in the management, what is the initial step in the management in order that their condition can be given that fetus is stable. So what would be your next step in the management, how you are going to manage this condition. So if the fetus is stable and there is 37 weeks of the gestation and the patient is experiencing for say BP more than 160 per 110 millimeters of mercury, so in that case you would be going to manage her BP and start antihypertensive. You can start magnesium sulfate in order to provide prophylaxis of the eclampsia. In case of eclampsia, there would be pre-eclampsia along with the seizures, and they are not going to be explained by any other cause, like there would not be any electrolyte disturbance, there would not be any neurological deficit, or any neurological cause of the seizure would not be there. So pre-eclampsia along with the seizures is known as eclampsia. And in case of pre-eclampsia, there is new onset hypertension after 20th weeks of the gestation along with proteinuria or end organ dysfunction. What are the risk factors? Now these slides that I have made, they give the detailed idea or detailed concept. These are the points that you should keep in mind. They can ask you by giving various options that what things are not the risk factors of the pre-eclampsia, or what are the things that are going or that most significantly contribute to this disease pathology. You should keep these in mind as a part of your concept. Like if a woman is a primigravida, that she is having her first pregnancy, or if she is having she is too young or too aged, like age more than 35 or less than 18, she is having multiple pregnancies, she is having chronic hypertension, diabetes, renal disease, history of preeclampsia, obesity, and other autoimmune diseases like SLE or APS, autoimmune antiphospholipid syndrome. So these are the risk factors that contributes to these pathology. And then there is pathophysiology. What are the underlying changes? You should again have these in mind, that there is abnormal placentation, there is endothelial dysfunction, vasospasm, ischemia, increased vascular permeability, proteinuria, edema, and organ damage, liver, kidney, and CNS. What is the classification? Now on the severity of the hypertension and the BP, if the BP is less than 160 per 110 or more than 140 per 90, it's mild. In case of proteinuria, there would be more than 300 milligram per 24 hours. And in case of severe BP, BP is more than 160. So if BP is less than 160, it's mild. If it is more than 160 per 110, it's severe BP. And along with the severe BP, if there is end organ damage like CNS, liver, renal, hematological deficit is there, and there is fetal growth restriction, then there would be severe hypertension. In case of eclampsia, there would be preeclampsia along with seizures. What are the complications that can occur in case of this gestational hypertension, preeclampsia? Eclampsia can occur HELP syndrome can occur. What does HELP syndrome stands for? It stands for H for hemolysis, E for elevation of the liver enzymes, and LV for low platelet count. So there would be hemolysis, elevation of liver enzyme, and low platelet count. Stroke, DIC, renal failure, and pulmonary edema. These are the maternal complications, and the fetal complications are IUGR, intrauterine growth restriction, oligohydramnios, prematurity, and perinatal death. So these are the various complications of the gestational hypertension and preeclampsia. Preeclampsia can lead to eclampsia, it can lead to HELP syndrome, it can lead to pulmonary edema in female that is experiencing her, or in her fetus there would be growth restriction, there would be oligohydramnios, prematurity, and perinatal death can be over there. So what are the prime goals in the management? Firstly, we have to stabilize mother, we have to control her BP if she is having severe hypertension and if she is having end organ damage. First step in the management is always control BP, and the antihypertensives that are used are slightly different from the antihypertensives that are routinely used. So these antihypertensives are labetalol, hydralazine, and nifedipine, and we have to give seizure prophylaxis in case of preeclampsia, and in case of eclampsia we are going to treat these seizures with magnesium sulfate. And while giving magnesium sulfate, we have to keep in mind the signs of magnesium sulfate toxicity. These can be cardiac arrest, these can be respiratory arrest, these can be reflexes arrest. Like reflexes would be absent. Monitor maternal and fetal status. What is the definitive treatment delivery? So they are going to give you various scenarios. You have to first control BP. For the seizure prophylaxis and management, you can give magnesium sulfate. You have to stabilize both mother and fetus. And in case of the definitive treatment, what is the definitive treatment delivery, depending upon the timing and the severity. Now there are various scenarios. 25-year-old primigravida, as we have seen that primigravida is the risk factor for preeclampsia. At 32 weeks, like in the third trimester after 20th week of gestation, what is the BP? 165 per 110, that is more than 160. So she is having severe hypertension along with proteinuria, along with headache and visual changes. Like proteinuria is there and end organ dysfunction is also there. So most appropriate next step in the management is we have to start labetalol and give magnesium sulfate. Why? So firstly we have to control her hypertension, we have to control her BP. She is at 32 weeks of the gestation, so we cannot deliver, and she is experiencing end organ damage, so she can lead on to develop the eclampsia. So we are going eclampsia prophylaxis like magnesium sulfate. So among these options there are various options like observe and repeat BP in 1 week. No, we cannot observe because she is having severe hypertension. Start labetalol, yes, we have to lower her BP down and give her eclampsia prophylaxis. Why we cannot deliver immediately? Because we have to keep the gestational age in her mind and start ACE inhibitors. ACE inhibitors are not given, they are teratogenic, or they cause the renal complications as well. Women with preeclampsia develops generalized tonic-clonic seizures. Whenever a woman with preeclampsia develops generalized tonic-clonic seizures, it means that she has developed eclampsia. What is the next best step? So what is the eclampsia management? IV magnesium sulfate. What is the not a risk factor for preeclampsia? Multiple pregnancy, primigravida, renal disease, these all are risk factors. Smoking is not a risk factor of preeclampsia. Keep in mind that preeclampsia has underlying pathophysiology of endothelial dysfunction, and its risk factors are the various conditions that influence these vascular health and vascular conditions. So smoking is not, although smoking causes atherosclerosis, but it is not the risk factor for preeclampsia. Preeclampsia is caused by multiple pregnancy, primigravida, and chronic kidney diseases. So this is all about a brief review or a brief introduction of preeclampsia and eclampsia that are also the part of obstetrical emergencies and the complications of the gestational hypertension. We are going to discuss more about obstetrical emergencies in our next upcoming videos. Thank you.